All right, guys, welcome to the AliDoIsWin podcast. So today I have an awesome guest, Dr. Michael Twyman, who is a world-renowned cardiologist. And we're going to talk all about cholesterol, some of the tests that we can do to be preventative regarding cardiovascular disease, and some of the insights into some newer tests, and basically everything about cholesterol. So Dr. Twyman, welcome and thank you for coming on.
Thank you for the opportunity to chat with your audience today.
So for those who don't know you, can you go a little bit into your background and how you differ from other traditional cardiologists?
So I'm a classically trained cardiologist. I did invasive cardiologist for many years, but really got interested in the prevention side of things because we kept seeing the same people come to the cath lab, and we were kind of putting Band-Aids on the Humpty Dumptys. It was tremendously satisfying work to help people, but I felt like they're getting too broken and we never really got them back to a great baseline. And atherosclerosis is common. It's the number one thing that's going to take people out, but you may have 10 to 20 years to intervene before they're going to show up in the hospital with some type of an event, a heart attack or needing bypass surgery or a stent. So just got really interested in, looking at tools and labs that really could predict, people who are at high risk and get to them at an earlier stage.
And how often would you say that somebody asks you, do they have to worry about their total cholesterol if it runs just a smidge high?
It's an everyday occurrence in almost every single patient. So I usually start with, cholesterol is a needed substance in the body. Without cholesterol, you're dead. So cholesterol wasn't put into you by God or the universe or whatever you believe in to give you a heart attack or stroke. Your cholesterol is very important for making your sex hormones, making your bile acids so you can digest the fats that you eat. It's critical to make the cell membranes. So it's a structural compound. But cholesterol is really fatty and waxy, so it can't float in your liquid blood. So your body has to make these things called lipoproteins, which we'll probably get into today. But the only bad cholesterol would be the cholesterol that's getting deposited in your artery walls. And if you're just looking at a normal cholesterol profile that everybody's probably had before, the total cholesterol, the LDL cholesterol, which usually is calculated, it's not usually measured directly, a triglyceride and an HDL cholesterol. The only two numbers that are generally useful are the HDL cholesterol and the triglycerides, because it gives you an idea of how metabolically healthy that person is. But a total cholesterol really doesn't give you a whole lot of information for most people, because cholesterol is a passenger in something called the lipoprotein. So it'd be like looking out at a highway and seeing the cars. Is there one person in the car? Is there 5 people in the car? The people in the cars are the cholesterol. And so that's what the total cholesterol is measuring. You really want to know how many cars are on the highway, and you got to directly measure that number.
I love that analogy, because a lot of the times too, a lot of my clients get a cholesterol panel done and they're like, oh, my cholesterol is really high, and they freak out. And traditionally, as you mentioned, most basic lab panels will do a total, HDL and LDL. And can you talk a little bit about what will contribute to the result of those numbers and why being high or being low matters or doesn't?
Sure. So, the way that they were traditionally measuring lipids, was very crude. They took your blood, they spinned it down, and the different, lipoproteins, the LDL, the HDLs, they would separate out and they would measure, okay, we got this much cholesterol in the LDLs, this much cholesterol in the HDLs, and then we add those together with the other stuff. This is your total cholesterol. So it's just a very rough estimate. But the cholesterol, like I said, it's waxy, so it's not going to float in the blood by itself. So you need these lipoproteins. And for the people that are watching the video, I always show people like a tennis ball. The lipoproteins are spherical. They got the white stripe on the outside of it. The white stripe is a protein that holds it together to keep it to be a circle. And it's like a cargo ship. The cholesterol goes inside, the triglycerides, which are energy, goes inside, fat-soluble vitamins, the A's, the D's, the E's, the K's, and then phospholipids, which are building blocks for cell. They all go inside the little cargo ship. And so when somebody says they have high cholesterol, well, it can mean a couple of things. One, their liver's making too many of these cargo ships and you're filling them up full of cholesterol. And so you have a production problem. Well, the liver makes them, sends them out through your blood vessels. The job of the lipoproteins are to deliver things to your other cells, your other organs. So your muscle, requires energy. Your muscles, need triglycerides. So the little cargo ships go out. The muscle cell puts out a receptor, a catcher's mitt essentially, grabs the lipoprotein, pulls it in, downloads what's inside of it, the energy, and then has to send it back to the liver. The liver then will have to put out its own receptor and get it out of the bloodstream. So some people have an issue that they're making too many of these things. Some people have an issue where they just don't put out a receptor very well, so they just keep circulating around, and more chances they're kind of banging into the arteries, and maybe they're going to get stuck in the arteries if the right conditions are involved. But once it's back in the liver, you got to put it into the intestines. And in about 20% of the population, there's a little gate that opens back up and then lets it come back in. So you have to figure out where the problem lies and figure out which of these three levers. Are you making too many of them? Do you not get them out of the bloodstream effectively? Or does your intestines hyperabsorb them or basically recycle them too much? And then you figure out which lever you need to pull on, and then you push on it. And then, their cholesterol in the traditional panel is going to improve, but you're mostly cared about, well, what did the lipoprotein number do?
And so obviously a basic lab panel is not really going to tell you what lever you need to pull and how they can confront that. So how can somebody determine what their approach is?
So there's a test, that's just called apolipoprotein B, or ApoB. That would be the simplest test. It basically tells you like how many of these little white stripes on the outside of the tennis ball you have, because it's those ApoB containing particles that are the ones that are going to contribute to plaque formation in the arteries. Now, they're not the necessarily primary thing, but if you have more of these ApoB containing particles, there's just more interactions with the artery wall. And if they get stuck in the artery wall, think of it's kind of like fly paper, it got stuck there, can't get out. And then the cargo that was supposed to be going to your muscles basically dies in the artery wall and gets stuck there. And now the body thinks there's like an infection in the artery wall, sends out the immune system to investigate what's going on. And the immune system starts a war in the layers of the artery, and that's how the plaque really starts getting initiated. But a traditional cholesterol panel really can't tell you what's going on. It's a snapshot in time. They put the needle in your vein, they're sucking out some blood, and snapshot in time. What was in your blood at that time? The challenge with that test is it doesn't tell you where those cholesterol particles are going. Maybe they're on their ride was supposed to be going to the muscle. That's fine. The only thing you don't want them to be doing is taking the detour and dropping their cargo off in your artery wall. So that's why just looking at a cholesterol number by itself really isn't going to tell you what's going on with your arteries.
And I find that fascinating because when Charlie and I did a session with you, just hearing how it even trying to get HDL up is almost like this futile process that so many people try to do because they're told that that's what they have to do. If you get HDL up, that's your good cholesterol. And that is, the path to health. But why is that wrong?
That's a great question. And, I usually start with this, focus on the ApoB containing particles first, focus on the things that are causing the damage. If you withdraw the damage, you don't need the HDL to be doing the cleanup job as much. And so there's been multiple trials of different pharmacological agents that have been shown to raise HDL. And this is where I kind of back into it that, I never say there's such things as good cholesterol or bad cholesterol. That's too simplistic. They're just cholesterol. The cholesterol that's in an HDL is the exact same cholesterol that's in an LDL. They're just different transporters doing different jobs. Like the only thing you care about is that cholesterol getting deposited in your artery walls? HDL has multiple functions. One of them is something called reverse cholesterol transport. The HDL goes into the artery wall, acts like a dump truck, pulls that cholesterol into the dump truck, gets out of the artery wall, and then drives it back to the liver. But the HDL is also very important in your immune system. So it is a metric of health if you have higher natural HDL levels. But that tends to mean you're exercising well, you're sleeping well, you have a reasonable nutrition regimen. But there's not data that if you're taking a pharmacological agent and raising your HDL, you're necessarily doing any benefit to that person. And there's definitely trials of the CTEP inhibitors that the people had more events, they had more heart attacks, they died faster raising their HDL with drugs. So HDL really should just be looked at as more of a metric of what is going on with your environment. There are some people genetically, they're going to always have low HDLs, but some people, their HDL is low because they're metabolically sick, they're insulin resistant. So focus on that part of it and see will HDL rise naturally with that part.
Yeah, I think it's LabCorp who has like some sort of algorithm where they divide HDL with something, and then it's their insulin resistance factor, but the person could be perfectly healthy and just have low HDL.
Correct. Correct.
Yeah. And so it can be so confusing because people literally are just like, I'm trying to improve that. And they gamify it and then it doesn't budge. And then they think that something's wrong with them. I'm sorry, go ahead.
No, that's it. And that HDL, yeah, the more that the research comes out, it becomes more and more complicated, and it just cannot be broken down into, if you have low HDL, that's bad, and if you have high HDL, it's good, because there's also a case where you may have high HDL because you have dysfunctional HDL. Your body's very inflamed. So if your body's immune system is very activated, you're pumping out more HDL because it's part of the immune system response. Well, that immune system, there's a test that you can check called myeloperoxidase, or MPO, that if you have high myeloperoxidase levels, it's very likely you have dysfunctional HDL. So you can have all these high HDL and think you're, heart attack proof with it, but you're actually having your arteries on fire. You got to go focus on the inflammation at that point.
Oh my gosh. And
yeah, that's why it's complicated.
So is there a total cholesterol number that would scare you if you saw that on paper, or is it?
On a traditional panel, if your total cholesterol is greater than 300 milligrams per deciliter, or your LDL cholesterol is greater than 190 milligrams per deciliter, there's a suggestion you may have something known as FH, or familial hyperlipidemia. So you may have a genetic abnormality where that LDL receptor isn't working well, or some other issue with an enzyme that's affecting cholesterol production. It's not a slam dunk that that's it, but you can go looking at different things that might drive it. It is important to know, to kind of trend those things. So if you're 20 years old and that's what your numbers have been, okay, it's probably more genetic, or, your mom or your dad or somebody in your family also has this, quote, high cholesterol. Okay, it probably is familial hyperlipidemia. But I've also definitely seen cases in people who are, kind of experimenting with their nutrition plans, had, quote, normal cholesterol. They go on a keto diet or they go on a carnivore diet and their lipids go through the roof. And they, get told by their doctor, you're going to die, you got to take a statin. Well, maybe there's some other things you can look at. Do they have an ApoE4 gene? Do they have something wrong with something called the Niemann-1 pick-like receptor in their gut, and they're hyperabsorber sterols? There's other advanced testing you can do to figure out what's going on when somebody makes a big nutrition change, and then they see these lipid panels, shoot through the roof.
I want to touch on ApoE4 because I have 3/4. So I just happen to have a little bit of interest in that because I've explained to many fitness professionals who do nutrition coaching how higher fat diets may not work for somebody. And then we'll get into statins. But if you can touch on having that gene and how maybe that approach with nutrition might not work for somebody.
So apolipoprotein E, it has 6 isotypes. So it's a gene that codes for a protein. And so there's an ApoE2, an ApoE3, and an ApoE4. And you get one copy from each of your parents. So you can either be a 2-2, which is extremely rare, less than 1% of the population, a 2-3, which is I believe 10%, somewhere in that range, a 3-3, which is about 60% of the population, a 3-4 is about 20% of the population, and then a 4-4, I believe, is around 5% of the population. So the greatest majority of people are going to be a 3-3 or a 3/4. The 3/3s have normal cardiovascular risk. They tend to, digest fats normally. They have a normal risk of insulin resistance, normal risk of Alzheimer's. The people with an ApoE2 gene, they tend to have less cardiovascular risk. Their standard lipid profile is generally lower. They don't tend to absorb fats the same way. The ApoE4s, especially the ones that have 2 copies of the ApoE4s, they tend to have a significantly increased risk of Alzheimer's because of the way the ApoE works in the brain. But the ApoE4s tend to have higher resting cholesterol numbers. They're at more risk of insulin resistance. And they're the ones that, if they go on a keto diet, tend to have an issue with the way that the fats get absorbed. So sometimes it's, their body doesn't tolerate the saturated fats very well. And if they switch up to monounsaturated or polyunsaturated fats, the body can absorb those in a, quote, better way. Because when they're absorbing the fats, they got to make these chylomicrons. The fat gets delivered back to the liver. The liver then packages up the fats again into different lipoproteins. So it's a fat absorption issue in those people. And it's one of those cases where it's test don't guess, because there's other SNPs and genes that are going to interact with ApoE4. So not everybody's going to respond the same. So ApoE4 doesn't mean you got to be a low fat diet, but if you had quote normal values, you change up to a diet doing keto and your labs got horrendous, well, then you got to work with somebody to kind of figure out what, fat concentration your body can tolerate then.
And just more testament to why a basic lipid panel can only tell you so much. So going back to statins, I do want to touch on that because I have many clients who just based on their total cholesterol being a hair over 200, they get handed a statin. Why do so many get handed those?
So statins are tools is what I start with, and, use the right tool for the right job. So, statins, should not be in the water for everybody, and statins aren't, absolute poison. So I don't fall in those either two extreme camps. So, the people who tend to benefit the most from the statins, they're the people who've already had events. They've already had a heart attack. They've had a stroke. They have a stent in their heart. They've had bypass surgery. And you're trying to put out the fire and prevent them from having their second events. Where the gray zone comes in is more the primary prevention. As I said earlier, cholesterol is just a vital nutrient that your body needs. The only problem would be that if you're depositing the stuff into the artery walls. So if you don't know what's going on with the artery walls, how do you know that you should be modulating that person's cholesterol? So if they're, and we'll talk about the testing in a little bit, but if they're low risk, lifestyle is really the goal then. If they're higher risk, then statin might be a tool in that individual. The statins mainly work by lowering cholesterol production in the liver. They put out less particles. And when that happens, the liver then is basically like, hey, we need cholesterol for ourselves. So it upregulates the LDL receptor. So the liver puts out more receptors to clear the blood so that it can get its own supply of cholesterol back. So that's how statins work from a lipid standpoint. But they also have some other effects. They do help endothelial function. They prevent the arteries from being sticky. They kind of thin the blood a little bit. They lower inflammation. If you have plaque, it tends to help stabilize the plaque. So it's turning stuff that's going to rupture and cause a heart attack into a calcified little rock. So it has other effects other than lowering lipids. But the people in your community, the big concerns is, the muscle side effects. That's the number one reason people cannot tolerate certain statins. They get myalgias, they get weakness, they get actual, muscle breakdown, which isn't that common, but that's always the concern is that they're going to get something called rhabdomyolysis. Extremely rare, but the muscle pains much more common than, is, generally reported. So, maybe up to half the people who try statins might have a muscle symptom at some point, but that doesn't mean you're necessarily quote allergic to the statins. It just may not be the right statin for you if the statin is indicated in the first place. And there's more testing that you can do. What is your CoQ10 level? If you deplete CoQ10 too much, that might have an effect on why your muscles hurt with statins. Are you vitamin D deficient? You're pretty much guaranteed to have muscle pains if you're vitamin D deficient on a statin. What is your thyroid function? Are you hypothyroid or underactive thyroid? More likely to have statin issues. We talked about the ApoE4 gene. If you have one copy of that, you tend not to tolerate the highest dose of the statins. You might tolerate more low dose or intermittent dosing. And there's other genes that you can check to see, is that person likely to tolerate the statin? So I think it's sometimes still too simplistic. They see, a nail, oh, high cholesterol, here's the hammer of the statin, push it down. Well, risk versus benefit. If you're trying to prevent their second stent or bypass surgery, there's probably greater benefit. But if you're a 35-year-old woman who just has, quote, high cholesterol, there's probably potentially more risk of getting muscle pain or affecting their glucose than you are at really reducing their heart attack risk at that stage.
And in the men too, it could theoretically lower testosterone as well. And
I honestly don't see that so much in clinical practice. And I know that's always the concern is that if you lower, cholesterol levels, you're going to affect the body's ability to make, sex hormones. That would be a rare occurrence. Every cell in your body is making its own cholesterol for the most part. And, the main job of the lipoproteins is really to deliver the triglycerides, the energy, and the other building blocks for the cells. Because cholesterol is so vitally important, those cells can't wait for the liver to produce the cholesterol and send it to them for the most part. When they measure your blood levels of cholesterol, that's really only between 5 and 10% of the whole cholesterol that's in your body. So most of the cholesterol is inside your cells already. So Now, there's occasions where our body's under significant stress. The body's going to have to deliver more cholesterol to the adrenals and the gonads to make more sex hormones. But that's not the rule. That's generally more the exception.
And are the more expensive lab panels like the Boston Cleveland Heart, do they help tell more of the story or no?
Very much so. I mean, you named kind of two of the companies. There's a couple other ones, but there's these advanced lipid companies that have different inflammatory markers, different genetic markers, and they just give you a better roadmap of what's really going on in your cardiovascular system. So, atherosclerosis is extremely common. There's 20 million Americans that are affected by it, and unfortunately, up to like 70,000 Americans die per year from heart disease. But this is a disease that really starts in your teen and 20s, and then you don't get it evidenced until you're 40 or 50 years old. So you have a lot of time to intervene before the symptoms show up. And by the time you have symptoms, you're kind of really late to the game. Yeah. So these testing really kind of help find out where you're at on that staging. And there's kind of 3 levels that you really require before the plaque forms. One, you have to have something known as endothelial dysfunction. That's the coating of your arteries. It somehow gets damaged and then things start sticking there. The second thing is you have an inflammatory response. The body thinks it's being invaded by bacteria or viruses, and the body has a local response, which would normally, if it was bacteria, would be great. But if you're attacking your own cholesterol, that's going to potentially lead to these fatty plaques in the arteries. And then the other thing is you just have too many of these ApoB containing particles going through the system. So it's kind of a shots on goal analogy. If there's too many, there's more chance that they're interacting with the artery wall. So you figure, again, which lever do you need to really pull on? And those kind of advanced testing will kind of guide you in that aspect then.
And so I know, like with my male clientele, with my guys, like, and in people in general, sometimes you have to show them like on paper, what their future looks like before they make a change. And often these lifestyle changes, telling them that their labs are not necessarily very good is not enough. But once I tell them this can affect their erection, then the light bulb goes up. Can you tie in endothelial health, nitric oxide, and erectile function, please?
That's a great question, because that's sometimes the canary in the coal mine is that, guys, classically, a lot of them don't go to doctors unless there's a problem. Mm-hmm. And sometimes the erectile performance or the ED thing is the thing that popped up in their mind. And, maybe they've been trying the little blue pills, as, we call them, and, say it's not a bad thing that you necessarily need to use them, but that should be a red flag is, why are you using it? Because the way those medicines work is that they make nitric oxide stay around longer in the system. And nitric oxide is a very short-lived gas that, from an artery standpoint, does 2 things. One, that nitric oxide causes the muscle in the artery wall to relax, so that improves blood flow. And the nitric oxide also acts like non-stick, surface. So whatever's floating through the bloodstream doesn't tend to stick to the artery wall. But if a guy is, suffering from erectile performance issues, that can be an inflow issue. They have issues with the small blood vessels that are providing, blood to the penis. You need blood flow to come into the territory. Then that causes the engorgement of the tissues that compresses the veins, and that's where the erection comes from. If the nitric oxide levels drop too much, the blood flow then leaks back out and the erection goes away. And so, I said, I'm not opposed to people using the little blue pills, but that is kind of, putting a Band-Aid on things, because it's not fixing why you have low nitric oxide. You got to go look why that person has it. And if you can fix that, then they maybe need less of the, the medications, or they can, use half a dose. But the big question is, if you have erectile performance issues, you very likely have, coronary issues as well. So it's one of those situations where it's test don't guess. If you got erectile performance issues, you need somebody checking out your heart as well.
So how can you test for nitric oxide production?
There's a couple of different ways. I mean, there's salivary nitric oxide strips, kind of looks like litmus paper. You spit on the little strip, and if it's bright red, you're making good nitric oxide from your salivary pathway. A rough estimate would be, your blood pressure. If your brachial blood pressure, the blood pressure you get in your arms is less than 120/80, you're generally probably making good nitric oxide. And then there's blood test. The kind of the poor man's way to look at it would be some test called the urine microalbumin creatinine ratio. That's something normally you get checked if you have diabetes or high blood pressure. But if you're leaking microalbumin, which is a protein, into your urine, that means the arteries of the kidneys are getting damaged, and that's function of endothelial dysfunction when that happens. Then there's a test, asymmetric dimethylarginine, ADMA. If that's high, likely have low nitric oxide. If you have high uric acid, you'll have low nitric oxide. If you have high homocysteine, you're likely going to have low nitric oxide. So that's the kind of the biochemical way to look at it. And then the mechanical testing, there's a device called the Max Pulse, which looks like a finger probe and looks at the elasticity of the arteries. Your arteries are supposed to be very springy, kind of like an accordion. So the blood goes through them and they're kind of bouncing. If you have really sick arteries, they're stiffer. And they're stiffer in part because they're not releasing nitric oxide. So you can measure the stiffness of the arteries. And then there's a test called the EndoPat, which is a good test that is non-invasively tells you how much your arteries can release nitric oxide when under stress. Can they double in size? Can they triple in size? Because if your arteries when under stress can release nitric oxide, then you have good endothelial function. So that's kind of the whole panel of nitric oxide testing, but start with, at home, you can get the salivary nitric oxide strips online, and then, rough estimate, what is your blood pressure? If you have normal blood pressure, you're less likely to have endothelial dysfunction.
So would you say, like, if a guy, because a lot of the supplements that are common, like citrulline and eating beets and stuff like that, if those don't work, and we've ruled out other issues that affect erections, like the biochemical and then any type of stress. So if it's a blood flow issue, if those don't work, does that mean they should get some of these tests done?
For sure. Yeah. That, if it's not something that's easily reversible, then, these advanced labs can kind of point you in the right direction. You uncover high uric acid or high homocysteine, you treat those things, then, the nitric oxide gets better. So, Mother Nature was wise. Many times, the best treatment of action is not more pills. It's remove the offending agents, do the deep dive, do the root cause analysis, what is causing it. So, yes, there are times and places to supplement up with things that can help the body, make nitric oxide or support nitric oxide, but that isn't necessary in everybody.
Because they have a lot of those pre-workouts, and guys are always asking for a supplement to fix something. Usually has to do with testosterone or the erection. And I think really hitting home on taking care of the lifestyle stuff to prevent that, because there's all these ED treatments nowadays that seem painful, but you literally have to go to an office. And I'm sure you've heard of the P shot and Gaines wave, and basically it's like a Theragun on the penis. So to not have to go through that, I'm just reiterating for those listening, sure, lifestyle things are good.
Correct. Yeah. It always starts with lifestyle. And then, there's, supplementation, sometimes medication. And then, then there's these procedures, and, and sexual health is extremely important as people, age. I mean, that is, one of the reasons that people want to have longevity is so that they can have a healthy, life and, do that into the late ages. And, it's not saying you're a failure if you ultimately need those things, but sometimes there's some easier options to start with.
And so how would somebody get ahead of this? So you were saying once they have symptoms, they're already late. So what's the best approach to kind of get ahead of all of this?
It's the kind of test, don't guess, analogy. So the biochemistry is important, but you really want to know what is going on with the 60,000 miles of blood vessels. So I mentioned a couple of the tests already, the Max Pulse, the EndoPat, those are kind of early stage findings. If you're not making good nitric oxide, the arteries start getting stiff. So you can measure, that. But if you want to know what the arteries are actually doing, the test that I recommend people who are, maybe under 40, there's a test called a carotid intimal medial thickness test. It's an ultrasound of the artery on the side of your neck. Not only will it look at kind of flow in the artery, but it's more looking at the thickness of the intima, the inner lining of the artery. The intima should normally be very thin. If the intima is thickened, there means there's inflammation in that territory, and it's very likely these ApoB particles are getting retained there. So thicker arteries, more likely to be developing plaque. And if you have plaque in the arteries, it'll be able to measure, is it, a 30% plaque, a 50% plaque. So generally you're going to find stuff before the person has symptoms, or, somebody, puts a stethoscope on your neck before they hear a brewery or turbulent flow in the carotid artery. But the CIMT test will give you what's known as your vascular age. So if you're biologically, 50 years old and your arteries are 80 years old, you're essentially 80 years old. There's a physician from the 1600s, Thomas Syntham, that is his saying, a man is as old as his arteries. Mm-hmm. So, Unfortunately, I know, a lot of the pro bodybuilders, recently have had some very untimely, events, or they've even unfortunately passed away. Just because you look, outstanding, physically on the outside does not mean that your arteries are aging at that same rate. So the test don't guess scenario, check your arteries on the side of your neck. If your arteries are older than they should be, do the biochemistry, try to figure out what's causing that, and then pull on those levers. So I would start with that if you're less than 40. If you're generally over 40, or you have a really strong family history, mom, dad, grandpa, grandma has heart events in their 40s, 50s, you're going with these tests earlier. But the kind of the starting test would be a CT coronary calcium score. It's a low dose radiation CT scan that's looking for calcifications in the 3 arteries that sit on the outside of your heart. Your calcium should be in your bones and teeth. It shouldn't be building up in your arteries. Calcium's a late stage finding. It means that the cells have basically necrosed or died. They become fibrotic, and then they calcify at the end. So if you do a CT coronary calcium score test and your score is 0, that means you're not late to the game. You don't have a lot of hard plaque in your arteries, which is a good sign. But in a minute, we'll talk about why that may not necessarily be enough in some population. But if your calcium score is greater than 0, that means you've had break-ins to your artery and you have more plaque than you should probably at a certain young age. The calcium score test is really good if you're young and it's 0, or if you're really old and it's 0. If you're really old, meaning like greater than 70, and it's 0, whatever you're doing is working for you. And those people probably don't break them. It's kind of that mid-zone range where if your score is not 0, you got to figure out what's causing that, because calcium is just a predictor that of events. The calcium isn't the biggest problem. It's the soft plaque that's sitting on top of the calcium that's really the problem. So sometimes you'll see the people post, my calcium score is 0, I can, live forever and I don't need anything. It's like, well, it just means you're not really late to the game. If you have abnormal endothelial function, you have an abnormal IMP, you're maybe like 3 or 4 years away before you're going to start calcifying the plaque. So, calcium score 0 is great, but it's not the be all end all. And I know you and some other people that we both know have done kind of the more advanced test, this test called the Clearly scan.
And which I found fascinating, because it's one of those things where I've been telling all my clients about it and telling friends about it. And it's very difficult to explain the difference between the Clearly test and then the other calcium tests, because a lot of guys are like, oh yeah, my cardiologist has me do the calcium score. And I'm like, no, it's different. So can you explain? Because it's a lot better than how I can explain it.
Sure. So the Clearly scan is a CT coronary angiogram. So similar machine that you're going to go through, but the process is a little bit differently. So you're going to have an IV placed. They're generally going to ask you to take a beta blocker before the procedure, which is a medication that slows your heart rate down. So ideally, they want your heart rate into the 50 or 60 range. So I know some of your audience, pretty hardcore exercisers, maybe your resting heart rate's always that low. But if not, they want you to have your heart rate slow, because they're basically taking a picture of a moving object. So the slower the heart, the less artifact will be present. So they put an IV in, they administer contrast, which basically will fill up the coronary arteries, and it allows them to take a picture of what's flowing in the artery. So the test will give you basically a calcium score test, but the benefit of the test is it's looking at the artery walls. So, plaque is pretty common, so the test is beneficial to say, like, is there certain stenoses, how blocked up are the arteries? But that's usually not the best use of this test. The best use of the test is to tell you, okay, you have the total plaque volume of X. What is that plaque? Is it calcified? Is it not calcified? Okay. But if it's not calcified, is it the low density plaque? It's the low density plaque that's more necrotic. It's red hot. It's a pimple ready to explode. That's the stuff you're really worried about. If it's really calcified, that stuff is, hard. It's not going anywhere. If it gets to be a large enough, rock in the artery, you may have symptoms. You may get angina. You may get exercise intolerance. You may get shortness of breath with activity, but that calcified plaque isn't as likely to rupture. And it's the ruptured plaques that basically cause the heart attacks. It's the ruptured plaques that spill out all this damaged cholesterol, this damaged cellular debris into the bloodstream, and the blood clots. So that's kind of the reason to think about it, is that your artery doesn't just fill up full of plaque like a sewer pipe. It's something abruptly ruptures in one of these plaques that are living under the walls of the artery. And the Clearly test is looking at those plaques and telling you, is this stuff super dangerous, or is this stuff kind of old and, is under control? So it can tell you, how aggressive to be with your lifestyle, your supplements and medications. And they just released a staging algorithm for the Clearly test, that has kind of like, stage 0, stage 1, stage 2, stage 3. And depending on the stage determines, well, how aggressive should you really be with certain pharmacological agents? So if you have a stage 0, stage 1, and you're kind of risk averse of taking statins or other agents, maybe lifestyle and supplementation is right for you. You're stage 4, or I should say stage 3, and you got severe plaque, well, you're getting close to getting headed to requiring stents or bypass surgery in some instances. Maybe you want to, throw the kitchen sink at that person to try to put the fires out at that stage. So it just helps you personalize your care much more intently.
So basically a CIMT and then a coronary calcium scan can tell you if there's plaque, and the Clearly will tell you what type of plaque and where that plaque is actually located and what to do about it.
Correct. I mean, the other two tests are still great tests, but the Clearly is even more fine-tuned. And because there's many patients that I've seen so far that have a normal calcium score test, they have a score of 0, and you send them for the Clearly scan, and they have, what I call baby plaque. They have soft plaque in their artery that hasn't had yet time to calcify. And there's, like I said, 2 types of this non-calcified plaque. There's the soft plaque that, has 2 options. It's going to calcify or it's going to regress. If you optimize the biochemistry, the plaque has potential to shrink down. So that soft plaque can shrink down. But what you really want to know is, do you have any of that necrotic low density plaque? Do you have stuff that's on fire? If you do, on your blood work, you likely have high myeloperoxidase or high LPPA2 or high oxides LDL. There's something that's going to point towards you got a fire going on and you got to put that fire out.
So even people who have no hereditary predisposition to a cardiovascular event, who are healthy from a lifestyle standpoint, may end up all of a sudden you can see plaque in their arteries.
So the way to actually think about it is that, if you live long enough, you're going to have some degree of atherosclerosis. The goal is to die from something else and not die from atherosclerosis. And this is just helping you stage, how far are you in that game?
That's awesome. Because I know I'll pull up a test in a minute for those who are watching the video. But this test is from a mutual friend who has a very healthy lifestyle, competed in bodybuilding, does all the right things. If somebody were to say, I do all the right things in quotations, and had a calcium score of 0, yet there's nothing that would have told him anything except for doing this test that he had this type of plaque, soft plaque. It's crazy. And it's almost like everybody should do this.
Almost, I think that'll be kind of the gold standard ultimately. It's just once they kind of get the, the test is clinically been around for, I think, about a year or so. So just kind of getting awareness of the availability of this test. There is, data that they're working on publishing that, shows that if you have X score, this is your risk of having events. So that type of data is coming. And once that's there, then more of the kind of the primary care doctors and the general cardiologists, they may feel more comfortable ordering this type of test because then they know what they're supposed to do with the result of it.
Right. So obviously we're going to get messages about this. How do I do this test? Where do I go? What do I do? So if somebody wants to do this with you, what is the next step for them?
Next up is just reach out to my office. I have a practice in St. Louis. It's called Apollo Cardiology. We focus on heart attack and stroke prevention. My website is my name. It's drtwyman.com. So it's drtwyman.com. And our phone number and contact information is there. If you're interested in the Clearly test, you don't necessarily have to be a patient of mine, to ask for the test. We would help you kind of get set up if it's available in your general region. And then we could set up a consultation to review the results.
And I'll obviously link everything because for you guys listening or watching, Charlie and I both did this. We went to an imaging center around the corner. We got it done. We took the beta blocker. It was the first time I had done contrast, which felt so weird with the iodine. They're like, you're going to feel like you have to pee. And I was like, okay, yeah, that's definitely a weird feeling. But we were in and out within a half hour. It's really not that big a process to go through. So it's fairly easy. And to save yourself any mental turmoil or emotional, just wondering if you have any predisposition, is huge. And I highly encourage anybody who is taking TRT on top of maybe other anabolics and stuff, because a lot of people do that, which those drugs can crush somebody's lipids, but this will help them determine their risk factor also, right?
Correct. Because it's, lipids are important, and not to say they're not, but what are your arteries doing with that information is the way to think about it.
Awesome. So I'm going to share my screen and pull up this test. And we will go through. So can you see that okay?
Yes.
Okay. So it says a sample physician report. I was going to do mine, guys, but mine is so boring because my risk is so low that it really wouldn't tell you much. So where would you like me to start? Just leave it on this page?
Sure. Just so start with the summary. So I know that this one is kind of the physician reports. I'll kind of break it down what this all means. So the first sentence, this patient has 313 millimeters squared of atherosclerotic plaque. Okay. So the first question is, is that a lot? That was the question I first had when I started doing these tests, was that, I had seen many patients with calcium scores of 0, and then they have, 200, 300 millimeters of plaque. Okay. I don't know exactly the data. Don't quote me on this, but I think it's less than 10% of people that do this clearly scan will have a completely normal study, have 0 plaque anywhere. So it's not going to be uncommon to have some degree of plaque, but up to about 250 is considered mild. 250 to 750 is kind of more moderate. And over 750 would be severe. So this individual would be kind of more in that moderate range. The PAV is the plaque atheroma volume. So how much of the plaque is kind of pushing into the territory where the blood is flowing. So 11% isn't that much. But then the thing that really differentiates it clearly from other tests is breaking down the types of plaque. So in this individual, the majority of the plaque is this kind of non-calcified plaque. So 281.2 of it is this soft plaque. Very little of it is this low density plaque, the stuff that's the necrotic plaque that's more likely to cause an event. So less than 0.3%. And then the calcified plaque was again, low at 23.7. So off the top of my head, I can't remember what this person's calcium score test was, if anything, but would have likely been a very low score. So very likely, under 100 initially.
It was 0.
Was 0. Okay. Yeah. So, different scanners might have slightly different scores. So I'm not really concerned that if it has 0 on one machine and this one shows, it's less than, 1% of the plaque volume is calcified. That's not his concern. It's really, you're looking at the soft plaque and how much of it is necrotic plaque. And then the second part, that would be a little bit more nuanced in that, this is an AI machine learning algorithm that's reviewing these images. So the absolute degree of stenosis, I don't want to say necessarily it's always going to be an overcall, but you kind of marry it to the patient's symptoms, if any, and any other testing that they've had done. Because if patients have a severe stenosis, meaning a blockage in one of their arteries greater than 70%, they may be at more risk of having symptoms when their body's under physical or emotional stress. So they may have chest tightness, pain, pressure when they exercise. They may get short of breath when they exercise or run upstairs. They may just have exercise intolerance. What used to be easy is now hard. So, just because you have a stenosis doesn't mean you're necessarily going to have symptoms. The stenoses aren't the things that are necessarily as concerning. It's more that, are those plaques going to rupture and cause a heart attack? Right. Now, back in the days when I was in the cath lab, put a stent in a blockage and reduce the blockage back down to 0. Okay, you're basically spot welding one small area in the artery and you've opened it back up. But you did nothing to reduce that person's heart attack risk or really reduce the risk of dying. The only time that a stent really is life-saving is when you're in the midst of having a heart attack and they're using the stent to stop the heart attack. If you're an outpatient just walking around and you have a, quote, severe stenosis that's causing you symptoms when you exercise, optimizing their lifestyle, optimizing their medications, improving the endothelial function, That's the stuff that gets those people to live longer. If you ultimately need a stent, that's not necessarily a failure, but the stent might relieve your symptoms, but the stent didn't fix why you got that blockage in the first place. And you got 60,000 miles of blood vessels. You're going to be putting more plaques elsewhere, and you're going to play whack-a-mole with those people unless you fix those other problems. So a stenosis on the Clearly scan, yeah, I'd be interested in it, but I would want to know that person, are they having symptoms, before I'd say, okay, you definitely need to go have an invasive procedure to look at this.
And to give you guys like some comparison with the 313 millimeters cubed
Yeah.
of plaque, mine was at 19. So it is a very sensitive AI.
Yeah.
And then,
and the nice thing about this test is it does kind of break it down by artery. So you got 3 major arteries that provide the oxygen nutrients to the heart muscle itself. You have on the screen here, the LM and the LAD, that's the left main coronary artery and the left anterior descending artery. Those are the main kind of thoroughfares to provide the nutrients to the heart. And so in this individual, the majority of their plaque was in their right coronary artery. So yeah, you'd prefer to have no plaque in your arteries, but if you had to pick an artery, you'd rather be in your right coronary artery, which is a little bit less important of an artery. And then the test is very good at telling you where this plaque is and where this low density plaque is. And this individual has a low amount of the low density plaque compared to the rest of the volume of plaque.
That's good to know. And then the one stenosis is indicated there.
Correct. And then the cool part of the test is this more for people who are used to look at images, but even for patients, it's nice looking at this because this is kind of like a roadmap. So your right coronary artery normally kind of looks like a C as it sits on the outside of your heart. And so they basically take a 3D object and stretch it out and make it look like a highway. And then you starting from screen left to screen right, going down the artery. And so in the middle part of it, that's white, that's where the contrast is going through your artery. So that can help differentiate, where the blood is flowing from, the rest of the cardiac tissues. And then on this image, the little areas that are lighting up yellow, those are the non-calcified plaques. So in this person, the plaque is mostly positively remodeling. What this means is that the plaque is mostly growing outside. So the artery is getting bigger. The lumen where the blood flows is not really being impacted. So this person wouldn't be expected to have symptoms with this. But the artery is sick. There's evidence that there's been some break-ins to the artery. The person's had endothelial dysfunction. They've had artery inflammation. Those ApoB containing particles have been getting retained there. But the real question is, are you still actively doing that? Or is this an old finding and you're picking it up now? So the person has a decent amount of plaque there, but doesn't look like too much of it is that high risk necrotic plaque that's really likely to cause the events. And that's really the only thing you totally care about with plaque in the arteries. What is this person's risk of having a heart attack with it? Now, if they have severe plaques that are encroaching into the lumen where the blood flows, they may start having symptoms. But again, that's a late finding. By the time you have symptoms, you probably got a 70% blockage in one of these arteries. So this person in this artery has a 25% blockage. Would not expect them to have symptoms from this. But you have these little, I call them like little time bombs sitting on the arteries. Are these things that are activated, or are these just like little rocks that are sitting there and you're just going to live the rest of your life with them? And in this individual, the non-calcified plaques are the most dense of the volume, but over time, those things can calcify or shrink down with the right lifestyle supplements and medications.
And so this is showing like plaque on the inside and on the outside on the image. And you said plaque on the outside is not as threatening as inside.
Not necessarily. It's just that there's any amount of plaque there. It's the plaque that would be, quote, inside the lumen. That's the plaque that's more likely to cause symptoms if it gets large enough.
Got it.
But that's why sometimes people can still have heart attacks, because half the times people have heart attacks, the blockage in the artery is less than 50%. They would have had no symptoms before this little red hot plaque ruptured. And so that's sometimes the first sign that somebody has that they have heart disease, is they're showing up to the ER with a heart attack. So you're sometimes fortunate that if you're having symptoms ahead of time, that might be that there's a sign that the plaque is a little bit more stable, and a stent will make the symptoms go away sooner. But you really have to figure out why that plaque was getting put there in the first place to stop it from happening again.
And for this person, what would be like the game plan afterwards for him to alleviate this or mitigate anything?
So doing one of those kind of deep dive advanced lipid profiles really helps. How much inflammation is going on. Do you have oxidized cholesterol? What is your ApoB? ApoB, it's pretty comparable, apples to apples, apples to oranges if you're changing companies, but you generally want that number to be less than 80 if you're starting to have any amount of plaque in the arteries. And there's some data that you probably want that ApoB number to be less than 60. So, try to change the circumstances where you're less likely to be adding to the plaque so that the body has a chance to stabilize things and maybe regress it. And then there are different, cocktails of supplements and medications, and all individualized based off of the patient's context, though.
Cool. So, all right. So for this is
the kind of the end part of the right artery is completely normal, which is not a surprising thing.
Awesome. So that's for that. And so basically doing this test can be the ultimate peace of mind to know what your true risk is.
For sure. And I was reading an article that they had put out on their website, the Clearly website. It's like, if you get diagnosed with cancer, they stage your cancer, say, it's got, your stage 4 cancer, the cancer's everywhere. And, we got to throw, chemo, radiation, surgery at you, or is this mild and, can be treated with just, excision. They should be treating coronary disease the same way. Is this something that's mild, moderate, or severe? And that determines how aggressive to be with it. Because risk factors are just that. There's people with cholesterols, that are 300 who have no plaque in their arteries and they eat horrible diets and they don't exercise. Well, they have something that's protecting their endothelium from getting damaged. Some people look like Adonis on the outside and they have severe disease in the inside and they're having heart attacks in their 40s. You just don't know unless you actually go looking at the arteries themselves. And that's, and then like in my old days, I was an invasive cardiologist. By the time you end up in the cath lab, you probably had to have symptoms or you failed the stress test. So again, you were late to the game by the time you would do an invasive look at somebody's arteries. And not everybody's going to sign up for an invasive test just to see what's going on inside. These non-invasive tests really give you that peace of mind. Okay, now I'm pretty low risk and my lifestyle is currently working for me. No, I found something before I had symptoms. I don't want to be like my dad who had a heart attack at 55. What do I need to do to start lowering that risk? And these tests help you with that.
It's just basically like preventative, just to know, because otherwise it can be too late. Because you hear way too often, oh, my friend just had a heart attack. He's 52. He's a marathon runner. And he's, and all these people who are seemingly healthy and just figured that they can just keep going on with their lives and had no idea.
Right. It's just the difference between, being proactive versus reactive. And in the old school way, it was like, we waited, you had a heart attack, we fixed you, but how about we don't let you get that far down the pathway?
Awesome. Well, thank you so much today for coming on and explaining this, because I think this is one of the biggest topics, especially with men's health and the confusion surrounding, cardiovascular drugs and erectile dysfunction. So I'm glad that you made that connection, because I hope that this is a good wake-up call for guys to take care of that and themselves.
No, for sure. And, it's something that, even as a physician, sometimes it might feel uncomfortable to talk about this with the patient, but this is something that is that canary in the coal mine. This is the red flag, the check engine light. So, somebody's got to speak up if this is something that's, affecting your life, because you or your spouse, might be the one that saves your life. If your spouse says, hey, he's really having issues in the bedroom, he gets his heart checked out and gets taken care of, he doesn't die early on you. So, talk to your doctors about this. It's not, you'll get over the embarrassment of, whatever, but, it's test, don't guess. There's a lot of things that can be done that can kind of get you back on the road to wellness then.
Absolutely. Awesome. Thank you very much, guys. I'll link everything to get in contact with Dr. Twyman's office if you want to do a test or another test or an interpretation. Do you also do interpretations of like regular cardiovascular labs with people?
I can do that as well. It sort of depends on what state they're in, determines, the intensity that I can do it, but I'm always available for kind of like second opinion educational consult. So if somebody just says like, hey, I have a local doc, but can you kind of give me your spin on what you're seeing in this or what testing I should do with my local doc? I'm happy to do that for patients as well.